I started my career as a clinician, specifically in cardiac surgery, and really fell into a leadership role, sitting in meetings, and I had no idea what the group was talking about because it was non-clinical, it was business. Continued to read and learn and grow, and then also to humble enough to ask questions.
I first lost a lot of money learning. I really do not regret that because that was a very good learning experience for me.
Welcome to Healthcare Business Growth Conversations. I'm Rakesh. Today, we are talking about a challenge that affects nearly every healthcare organization, but rarely get discussed openly. Joining me today are Jack O'Connor, healthcare executive and leadership strategist, and Dr. Ramzia El Annan, clinician, entrepreneur, educator, and founder. Between them, they have spent decades helping healthcare professionals bridge the gap between clinical excellence and leadership effectiveness. Today, we are exploring the leadership and business skills healthcare professionals are never taught. Jack, Ramzia, welcome to the show.
Thank you.
Thank you.
So let's start with a question that gets right into the heart of today's discussion. So when does clinical excellence become a liability rather than advantage?
Sure. I think anytime that a physician or a clinician is put into a role based solely on clinical expertise and not looking at the entire scope of their skill sets, whether they have any leadership abilities or any sort of formal training, at that point it really becomes more of a liability unless there's a very strong infrastructure in place that can mentor and guide that physician or clinician as they're in that new role.
Yeah, Ramzia, same question.
Yeah, definitely, because when we go into clinical practice, we're always focusing really on how good we are and on how best we can perform in a round or like planning a SOAP or planning a decision for individualized clinical care for patients. But we never look at the whole picture, whether this is going to be benefiting the system itself in the long term with having good quality control, quality assurance of providing the exact care for each and every individual in an institution or in a private clinical practice. So really skills are not taught in healthcare schools or in medical schools or even pharmacy schools from my experience as a doctor of clinical pharmacy. But however, they let us figure it out on our own unless you really are exposed and are present in a clinical setting where you would really have that in-depth experience or you start making mistakes to start realizing that, yes, this is where I'm stuck and this is where I really have to start learning from a different perspective on how to deal with these issues, even in clinical practice. Because even if we're dealing in clinical practice, we're not really dealing with files. We're dealing with the humans. It's people that we're dealing with. It's the people we're working with around. So all of these impact really the results that we get, no matter how good of a clinicians we are.
Yeah. So can either of you think of a specific moment where you saw that happen?
Myself, yeah. I actually learned from my own mistakes when I first decided to open my first business, which was a pharmacy. And this was mainly the best learning experience that I received is because I first lost a lot of money learning. And I really do not regret that because that was a very good learning experience for me. And really going in depth between finances, between be able to budget for my own inventory, be able to divide like the payments in between what I'm going to be putting in decoration versus really budgeting for the medications or the cosmetics in my pharmacy. Moreover, like I was left like without really marketing budget at the end of the day. And this is when my struggle started. I didn't even think of the extra budget that I have to put for operation. I thought this is budget, this is where I can only start my business, but never thought about like other, extras that could be hidden costs in the business. And this is when I started struggling and being worried and thinking of how am I going to do it? Because you always have to have that extra inventory, the budgeting, the marketing in place. So there were lots of things that were missing in that calculation and that formula, which had led me to start being curious of how to do things better. And this is when I knew that the marketing course that they give us in a pharmacy or in a medical school or the management course are not really enough. It's more in depth regarding each specialty by itself. And you always have to individualize the setting that you are in and how you're dealing with it.
Yeah, all right. So, Jack, do you have any good story that you can think of?
Yeah, this is a little bit different perspective or spin on the question. So, my experience or my story is related to creation of a new service line in a health system that pulls together physicians from different specialties within that service line, and putting one particular physician in charge of the group. And at no fault of their own, physicians are trained to always have the right answer and come up with it very quickly. And there's usually not a lot of discussion or consensus building with their responses. So what I quickly learned in that setting was we didn't have a team or a committee. We had one leader who was, in essence, not listening to the other experts around the table when it came to their specialties, and that group really, in a short amount of time, disintegrated into competing factions versus what the goal of that group was, which is to create a service line and improve patient care for the health system within that specialties or set of specialties. So my experience again is there's a huge gap in what physicians are taught or learn in medical school and the ask in the real world, which is to become a leader for either an entire organization or a subset of specialties within the organization.
Yeah. So, what's interesting is that nobody becomes a clinician accidentally, right? It takes years of education, training, repetition, expertise, and as you said, we expect them to be right and also make quick decisions every time. But on the other hand, leadership is a very different journey. So, in your experience, how difficult is that identity shift for any clinician?
I'll answer first because I've done it myself. So I started my career as a clinician, specifically in cardiac surgery, and really fell into a leadership role, kind of like what you described, just by chance, where there was an opportunity and they asked me to do it. And I can recall sitting in meetings and I had no idea what the group was talking about because it was non-clinical, it was business, and so having to quickly learn how to number one, continue to read and learn and grow, and then also to be humble enough to ask questions and not act like I knew what was going on, but really trying to ask some intelligent questions just so I could learn quickly what the group was asking of me. So it's I think for most people it's an incredible difficult journey. Some make it and some don't. It's just a matter of are you willing to put your ego aside, which you need to have a strong ego as a physician, to being part of a group and learning how to interact within that group setting. And I'll let Dr. Ramzia respond.
Yeah, and from my perspective, it's a little bit different because I'm more involved in clinical practice and in direct patient care. And I was really a sole entrepreneur. So it's the decisions have to be made fast. I would have to look always for the gap in the market, and I have to analyze what are the services and the techniques that could be needed, but still that could be cost effective. So this is where my challenge was, because I was the sole person who has to act quickly, but also at the same time connect too many people and to a lot of industries from different backgrounds. So I had to have this cross-cultural training on my own. I had to understand the different systems and the structure, how they work. For example, whether I want a brand, because I built my own cosmetic skin line brand. So this is when I started learning on how to learn on my own the different procedures and different health countries, totally different. Also, I have also how to speak in front of like an audience, to be able to make people aware, not only educate my clients and my patients directly, but now seminars, educating a bigger number of people until really I was raised on that ladder to reach a point where I opened my own academy from having just a small business into really expanding now to different countries. I started looking more at the bigger picture on how to implement franchises, how to expand a mega marketing for my own brand. So that had led me to really learn a lot of a variety of systems internationally, as well as read people's behavior, the culture of each person. How do they respond to these questions if I were asking such things? And where is really my maximum ceiling? So in that case, given my expertise in some of the institutional and experience, my residency, I saw a huge difference when now you are the only game changer. You are the only person in the field, and you are the sole decision maker. And despite that, even if my decisions were solely depending on me, but at the end of the day, I had to learn how to delegate jobs to other people, because perfectionism in entrepreneurship is really sometimes an enemy. So in clinical settings, we really want to be perfect. We want to give the right answer. We want to be those people who are the smartest in the room. To entrepreneurship and leadership, really, we are not acting here with authority. More, we are influencers. We are acting as part of the team members to let the ball roll on its own. And even with minor mistakes, we have to give that chance to other team members to do their own thinking and their own analysis and act accordingly. And we need to accept that fact. So in being an excellent and a professional clinician, really that was hard sometimes to accept, because I wanted to do everything on my own until I reached a point where I'm either losing now time, or sometimes I'm really not doing one task in excellence where I should have been doing it differently. So basically this was my main perspective.
Yeah, I think you both touch like into different things. Like Jack said, you gotta let your ego go, and then you said, no, you need to let your perfectionism go, let it go, and then delegate the things. Like both of you, if I ask you to pick only one, what is the first thing that a clinician has to let go to become an effective leader? What would be that one?
The one thing that clinicians actually have to unlearn is basically to be consistent with the system that they have learned in hospital. So we can't really, for each problem, we have to find a prognosis, and we have to list like a variety of this. So it's more calculating the way of how to solve problems in leadership and in executive leaderships, or in running like those high positions. We do not calculate steps. We really look at the whole picture, and we think strategically. We think of how this system is going to benefit us in the long term and be sustained on a certain profit that will help teams and not help persons. So we're not really individualizing here anymore or making a plan for one person. We are really taking care now of a structure, of a system, of a hierarchy, where we really are looking at it from a different perspective. And this is when we have to train ourselves and learn on how to start thinking differently. But sometimes things are born innately with people, and some people just they don't fit for those positions, even if they are trained. So and this is where the biggest question comes through, is how do we define those people who could be in those kind of positions, or they could be just happy as they are in a clinical setting. Nevertheless, that the clinical setting, we're not saying that this is not something not good. No, it is really, people are very happy with their positions. Sometimes they're very highly paid, but this is what their expertise and their excellence relies on is just the clinical setting. People sometimes are born to be leaders, but also they are trained to be leaders. So this is where the main difference comes into place, is by the questions that people ask. So as Jack mentioned earlier, he told you, I started asking, and he was so humble to ask. And this is where the difference comes between a leader and an executive. Yes, you raise up in title, but we don't depend on the titles. We really depend on how much we can delegate, and we can be informative for other teams to make the system grow, and not for ourselves only to grow.
Yeah, perfect. So, Jack, do you still stay with the ego, or do you have something else that you pick as the first thing?
I mean, I think it goes hand in hand, but I think the first thing that they need to let go of is always being right. And what I mean is, if they're quick to answer, and they're always giving their opinion, and they are adamant that their opinion is correct, it's going to shut down the rest of the room. So you're not going to get any dialogue amongst the others. And that's really how you come to the best decision outside of the clinical setting. Is there's so many perspectives and angles as you're making a decision for a hospital or a health system, that letting everyone speak, and then coming to a decision at that point is how you arrive at the best decision. So I think that's it. It's partly ego, but it's letting go of I always have to be right.
So, yeah, going back to Ramzia, Ramzia was just reading out a few of the posts that you put, and then you wrote that credentials open the door, but what happens once you're inside the room is completely different conversation. Like, what is a conversation? Could you please expand on that?
So from a private setting, in clinical conversations, we could be really talking to marketers, we could be recruiters, it could be really hiring new teams in order to delegate a job for them. It could be any discussion regarding budgeting, strategy, or new ideas. And I focus on new innovations because we can do that without going back to a huge team in a hospital setting, and we don't have to rely on a structure, on a policy, or a standardized methodology that is preset there for us. So in entrepreneurship, yes, this is really nice, but it's at the same time it's risky, because now you are the sole person who is deciding, and whether it fails, then you fail the whole business. So this is, it has a huge risk, but then with the market and with the fast delivery of new technologies and innovations, you really have to be curious, but at the same time, you have to think wisely. So if you do not really do the correct research, and you do not find the actual gap in the market and act quickly, then you will lose. So this is why sometimes this could give you a pro and a con in a room where you are really discussing all of these issues, because now you are thinking, okay, budget wise, but you are still thinking also marketing wise. At the same time, you are thinking branding and expansion. So all of these could go hand in hand, and it's a huge vision for business, whether it's small or big, to be really the sole presenter of the whole idea and to make it happen. Because in entrepreneurship, you may have tens of hundreds of ideas, but would you be able to implement all of these and be profitable? Even if you implement them, sometimes you may not really lead to a structure where you could have sustainable income out of it and benefit others as well. Or repeat the idea in a different country with a different culture, and at the same time be able to deliver the idea correctly and apply it to the rules and regulations of the ministry. So this is basically the challenging part, which I go through every single day, because I feel like I'm not micromanaging, but I'm really managing a lot of sectors in business where I was not trained at in the pharmacy school.
Then when did you first realize that credentials weren't enough?
I actually realized it early enough in my career, because I've always had passion for learning more. After I finished my doctorate degree, I just felt like this was not enough, and I wanted to go for the residency. And this was the first change in my life, where I had to leave my own family. I had to leave my country. I came to a different country, which I didn't know anything about. I was still too young. And at the same time, I didn't understand the culture. So, given that, yes, I did study in American schools in my country. We had private schooling, we had the best education ever. But at the same time, when I came first to the United States, it was really difficult for me because first I couldn't tell, like, when people talk to me, what did they mean. I could not really understand the system because our hospitals operate differently. I There are lots of rules and regulations that I had to follow and that I had to learn. And I remember one word my preceptor told me at the beginning of my residency, because when I did my entrance exam, I got like top grade. He said, even your bonus questions, you got it right. So you need to put your own list of training and you need to choose your own rounds. And I remember one of those conversations that I had with my preceptor. He told me, Ramzia, you are already a doctor of clinical pharmacy, and you are not here to learn pharmacy or learn only how to run rounds, but you are really learning the skills of life. And this I can take with me like for the rest of my life, because that was the word that has given me a lot of influence on how to change now in my character, learning the skills on how to learn better. So a university really is just a phase of you learning the basics, even in medical school, because you really have to be self teaching yourself for the rest of your life. So it's an ongoing process that never ends. And this is what I've been doing. And I've been teaching myself every single day new things and learning more and developing myself even better, because it's really about personal development and not only about opening my economics book or just learning on how to calculate dosing schedules and be able to diagnose correctly. So this is really was a game changer for me.
Yeah, so it's good that you realize it way early. I think only a few of them can do that, and their early careers without learning, without making big mistakes, right? I'm sure you might have made few mistakes, but it's good that you learned it very early in the stage. So I just want to move to Jack here. Jack, I just want to go back to whatever you said on that healthcare trains people to avoid mistakes. So, yeah, like on that line, can I assume that now is healthcare accidentally training people to become poor leaders?
Um, Honestly, it depends on the organization. So I would say this is a generalization, but I think in healthcare in particular, people are identified or tagged as a potential leader strictly based upon their skill as a physician or a nurse. So many times, and I've worked in a variety of health systems, a nurse is put into a director role as an example with no leadership training, no business training, and they fail miserably. And the same for physicians. And I think it goes back to the premise that you're used to making a decision quickly and your decisions are usually correct. And as odd as it may sound, I think someone who's potentially a mediocre nurse or not the best physician doesn't have that same confidence level. So they develop the skill of, like I described earlier, which is I was in a room that I had no idea what they were talking about, and I was comfortable enough to ask questions. So I think those individuals have the ability or have learned the ability of, I don't know this, so I'm going to ask. And they're used to developing that skill set of building a consensus or, talking to their peers and valuing someone else's opinion versus, the top physician, as an example, who you want them to be the best physician. That's who you want working on you, but they're not necessarily the right person to lead the organization into the future just because they're so egocentric on themselves and their skill sets, and rightly so. But that doesn't translate into what a leader is. And not to go too far off the rails, but one of the things that I always advocate for and try to manage or lead myself is through servant leadership, which is really about serving your team and serving others and not promoting yourself. And I really feel like that's probably the best strategy for a leader, particularly in healthcare. is to try to model yourself along those lines versus self promotion.
Yeah, it would really lead to a huge cost actually on our end, because in a clinical practice, we really, if we are good clinicians, we depend on the traffic that we get into a clinic. So with that traffic, really, we are very confident that we are going to present well. We are going to do the right thing because we have the expertise, we have the techniques, we have the technologies, and we do have the innovation. But when it comes really to the cost of understanding how we can transition into that leadership part and into really not being the experts in the room is where the challenge comes. So here we have to really start thinking about the teams as well as the long-term effect that this is will affect our institute. It's a little bit different in Jack is saying, because now Jack is probably training that nurse and that team, but in our setting we have more clinical contact because we are first in a smaller space. Second, we are in always constant contact with these people, and we have to find a way of communicating better, and choosing our words when we want to like raise a problem or like tell them about something not to be done the way that they have done it, just to be able to choose the correct words of leading and influencing and how we could have done it better, not how they should have done it better. So I always rely things on my own, on how I see things from my own perspective, on how I would have done things that could have changed the whole equation, rather than just pinpointing what mistakes they have been doing, because they could go through a lot of struggle, through a lot of stress, especially when they are faced with the clients that could not be happy sometimes about service, and they would just feel that they lost all their clinical expertise and they don't find the right words to say it in those situations, or be able to explain from a clinical perspective why this way, or why it cannot be done that way. So it's really, communication is a very important part of that. And I always try to train my teams in a way without being authoritative, without making them feel that I'm an authority. I want them to really lead, and I would give them that space where they would decide on their own, and I would give them that authority even if I know their answers are going to be different than mine, and I would let the system just to grow that way, just to keep encouraging them and influencing them positively.
Is healthcare actually training people to become poor leaders? Then whose responsibility is it to fix so that we are not going to train poor leaders? Is it the medical schools, or is it the hospital systems, or is it the professional organizations, or the whole responsibility lies on the individual clinicians themselves?
Yeah, what I believe is, well, of course, this has to be like a whole change of a system and a structure of the medical schools if we were to emphasize that, because from an advocacy point of view, yes, we can advocate to exchange it, because I've been through that route a lot, and I've tried to change a lot of policies and procedures in like institutions in my life, especially like given not only in the clinical settings of aesthetic medicine of what I do, but also in other organizations and non-profit organizations as well, and the boards of pharmacies internationally, like between Lebanon and other Middle Eastern countries. And until now, I'm doing the same thing with the government here in Canada, where I'm trying to advocate for changing policy to lead doctors to diagnose things better, but at the same time, not to only diagnose, but to build a system for children with feeding disorders. So this, I have been through that road, and I know it's really difficult sometimes to convince systems to change quickly. And this is the drawback in big institutions come, because everything has to take so much time, research takes time, and things do not change quickly. But if we want to do something that would be impactful on our teams, is to start changing within ourselves and show people and draw ourselves as an example. So we can lead by an example. We can speak out, we can be more informative, we can do more webinars. And this is why this platform that we're on right now is really very, very helpful, because otherwise, who is going to hear us if we are not raising our voice? So we have to always find the correct platforms, not necessarily digital platforms, the platforms in our clinical setting, to always find the correct time and where to speak to our team, and to encourage really people to think strategically and think as leaders. So not that I'm saying that thinking as a clinician is bad. No, of course not. There are great clinicians in clinical settings. They really fit over there because this is what they are excelled to do, and this is where they fit. But when we are talking about people who are curious to change, and that transition from being a beginner leader to an executive leader is where we have to come to have really this teamwork and really implement those learning habits from our own experiences.
Perfect. So I just want to move on to another question to Jack, especially here. So Jack, what is the hidden cost when a brilliant clinician becomes a poor leader?
If you could just give me 5 minutes just to respond to your previous question, just because I have a completely different spin on that question. So for the U.S. system in particular, the dilemma is, and I'm old enough to remember this, when I started my clinical career, the majority of physicians were private, were independent. They knew how to run a business because they ran their own businesses. So when that trend to shift to becoming employed by the health systems occurred, there wasn't a huge gap in at least leadership for physicians because they had been running their own businesses for decades. So they knew that skill set. Now, as that group has retired and you've brought in younger physicians, they've just come into an employed model. So they don't understand or have the skill set to run a business because they've never had to do it. So for me, that's the biggest gap. And to your question of who's responsible, I think it really just depends on the organization. So if the organization's strategy or vision is to be physician-led, then the onus is on them to develop a training program to train their physicians, because you want them to learn what you want them to learn. You don't want a generic plan. And to Dr. Ramzia's point, I did this myself. So I was a clinician. I went to school, got an MBA, and I equate that to you've gone to medical school, but you haven't done your residency yet. So you know the theory, but you don't know how to implement the theory because you've not actually had hands-on experience. So I think it's great if physicians go to get a formal MBA, but I really think it's upon the organization to develop a physician leadership academy, which is something I've done, and really train their own docs. So sorry, thanks for letting me have a few seconds for that. But the hidden cost of having a good physician become a poor leader, I think that was the question. There's many hidden costs. I mean, I think the first is kind of what I described in that earlier example. So you've got a physician who's a leader who is used to running his own show, and because of his leadership skills, has the rest of his group or the leadership team for a service line become disengaged because their voices are never heard. So what could be a very successful clinically and financially set of services for an organization never materializes, or doesn't materialize in a way that it was envisioned. So I've experienced this myself, where we were starting a new program and the lead physician in essence killed the recruitment efforts because he was threatened by the physicians that were being recruited, and it totally delayed the project for over a year. The other hidden costs are you're going to have staff turnover. You're going to have people leaving because they don't want to work with this leader, this physician who again, doesn't build a consensus, they're just in essence always right. So that also leads to poor engagement. One of the last things I can think of would be, you're not going to have a good business model or a strategic plan because your leader is not allowing others to participate or valuing the opinions of others, so that you're able to get a complete, robust strategic plan or business plan, because the other people in the room are not comfortable enough to speak their minds or aren't given the opportunity to speak their minds. So I'm sure there's others, but those come to mind for me as the top things that I've experienced or I've seen, and I think that's probably the best examples I can give you.
Yeah, so like, who pays that cost first? Is it the organization or the team or the patients?
I mean, at the end of the day, it's the communities that you're serving, because the example I'll give you, I'm not going to go specific enough so that it compromises anyone, but the example is there was a particular service that was needed in a community that I worked in, that if we did not have the service and you had to take a patient who would show up at your emergency room, as an example, and you would have to fly them or drive them an hour or 2 hours away to get the service. And as with anything else in a clinically emergent situation, either you're on the clock, so to speak, and you have to get this procedure done in a certain timely fashion, otherwise there's negative outcomes for the patient. So your question is, the first people that suffer are the patients or the community that you're serving, and then the next people that suffer are probably the teams that have to work with this leader, and then lastly it's the organization itself, because the person that you're asking to lead is not allowing their vision to fully materialize just because of their lack of leadership skills or poor leadership skills. So that would be my response.
Yeah, so it's the community that gets affected first, then the team who is working around, and then eventually it's the organization that's gonna gets affected and pay the cost. So Ramzia, do you have any such story that you can share with us today?
Yeah, definitely. It's actually similarly to what Jack was saying, but from a different perspective, because now we are running, let's say, polyclinic. So basically, the cost is a loss, a three-dimensional loss. Okay, so it's going to be a loss for the clinician, a loss for the team, as well as a loss for the patients. But in different ways. Okay, so the clinician now, yes, will stop being, encouraged to do the things that they like to do it their own way. If you're not giving them any independability of decision making, or giving them the environment where they would feel comfortable enough to do the things they want to do in a polyclinic setting, if we want to say. And this will really make them discouraged and to wanting just not to be leading, but just to go back into regular clinical settings where they would trade their hours for dollars. And this is when you start losing the best clinicians in your center, because they're not being able to be independently making their own decisions, but they have to always go back to one manager, one leader, and one entrepreneur to do what they have to do. As far as the team, really, the team building, the team working together, even if the team is non-clinicians, I'm talking about the team in general, who could be the secretary, who could be the helper, who could be the assistant, she could be the administrator. I'm talking about the variety of the different teams that will really start being competing, but without really having any authority. So even if they're competent in their jobs, even if they excel in what they do, if they don't have the authority to decide when I'm not there in the center on their own and to take that decision, but always they have to get back to me, then really this is when the teams start failing. Because if you don't give the privilege to each person on their own within their scope of business and their duties and their responsibilities to really decide for their own scopes, then they would not be feeling any happy anymore, and they would feel challenged, because they would always feel that they are taught to to do the things that they only have to be told to. Okay, and the big cost would also come on our patients, because at the end of the day, the profit is coming from that patient traffic. And if we fail the team and we fail the clinicians, then definitely we're failing the patients. The patients will really erode the whole system, because now there is not good communication with the patients. The patients might start to complain. There is not compliance with our, let's say, for example, given appointments. There is no compliance with follow-ups. There is no compliance with callbacks. So there are lots of things that the patients will find to complain about a system if we are not really all working in harmony as a medical team. So really the cost is huge on a lot of aspects, and not only on one person or another, because in a private clinical setting where we are all working in a very enclosed place and all together facing each other every day, that will create a little bit of tension among the groups. So if we don't make people understand and communicate with each person, knowing that they understand their duties, their responsibilities, and the limitation where they can cross the line or where they cannot cross the line, but at the same time be compliant with owning their own ideas, then this is when the whole system really will start failing. So we're really competent, but we cannot decide for our own selves. We're really influencers. We want to draw a line of not being authoritative. So basically, this is it.
Yeah. So I just want to move on from the problem to the transition itself. So I just want to start with Jack on this one. So Jack, when you're evaluating emergent physician leaders, what signals tell you someone is ready?
Yeah, it's a good question. I think it's imperative that you are building relationships with your physicians, and I think as part of that relationship building, you can discern whether someone has natural leadership abilities, and how well that they collaborate with their peers. So I think those are the two things that I'm really looking for initially. Number one is, are they willing to learn, and are they humble enough to realize that they don't know everything that's going to be asked of them, and then how well do they collaborate with their peers, that sort of thing. Those are probably the two biggest. I don't think you ever truly know until somebody is put into that role, but as with anyone, they have to be humble enough to admit they don't know everything, and they're willing to put in the effort to learn the different terminology or skills that they need to learn and grow. And on the flip side, I think you have to have a reasonable expectation that this is not going to happen overnight, that it's going to take some mentoring, probably for the better part of at least a year before that person is likely where you want them to be from a leadership standpoint.
Got it. So if I flip the coin, and then if I ask you what signals tell you they are not ready, what would you recall?
I think it goes back to someone who's very egocentric, who dismisses others' opinions without even fully vetting them. The person that always needs to be right. I think those are all key indicators that this person is likely not going to be a good leader, just because they don't have the ability to build a consensus or even value others' opinions. So I think those are the initial red flags for me.
Got it. So I'll move to Ramzia on the same topic, but with a slightly different question here. So Ramzia, when clinicians enter your academy or leadership programs, what's the first habit that they typically need to unlearn?
Basically, the first thing I would say is genuine curiosity about people. So if they are curious, and if they start asking open-ended questions about the system and not about how to document a clinical profile, how to fix that procedure, or how to diagnose correctly. So it's not systematic, but it's more a greater vision and a provision. this is when I know that the person is starting to be ready. And when they start asking those open-ended questions, is why this team is performing better than this other team, why this person can bring and draw more clients than this other person. So what's the difference? And this is now they are starting to compare leaders in the team. So basically, this question can be a big question that has a lot of explanations behind it. Is because when a patient, when a clinician starts telling you, okay, if we do this procedure differently, or we have to apply this rule and we have to document it this way, the way it has to be done, then you know that they are really thinking systematically, step by step, as if they are really opening a medical profile and just preparing a soap note. Okay, or they going on to the way their brain is functioned to learn in medical school. In signaling those people who are really or could be leaders is when we know and we can see their passion to change things differently and to see things from a different perspective by asking a variety of different questions. Example, how we could, let's say, choose this technology, but be able to combine it in a different protocol, which we can market it and draw 100 extra clients, let's say a month, that will give me strategic sustainability in the next year and a higher income. So now they are thinking really for the benefit of the system rather for the benefit just of how I would have done that microneedling technique or that dermal filler injection for this client differently. Do I have to look better at how I learned the anatomy? So they are still limited. So when they are still limited, you can tell automatically how they are effective, whether in like comparison to a doctor or to a clinician who would come to you and who tell you how could we do these things better. They have to be really humble enough to say that they made a mistake and they are wrong and how they could have learned it better, because they want to learn it better in order to implement it for the structure and not for the medical profile.
Yeah, I think the key is be humble enough to ask
Yeah,
those open-ended questions, right? Yeah. So,
humble.
uh, yeah. So, what are the signs someone wants authority now, but isn't actually ready for any kind of leadership role?
So some things I read in people is really their body language, their eye contact. So it's beyond their knowledge about business or about how they could run or lead, because a lot of the times you see leaders who really know a lot of management, a lot of economics. They know how to read budgeting. They know how to recruit people according to the policy procedure. But when you meet them in person, they're not the same people who you're reading their qualifications on a paper. So personality gives a very strong impact on that aspect, because it's really about how you act, how you speak, about the etiquettes that you go along with life, about how you can have really emotional intelligence and really be really able to read people and snap quickly how to react according to cultural differences. From my experience, because I've had to deal with a lot of multicultures and a lot of people from different backgrounds. So I had to learn as I'm listening to them, and I was an active listener, and I would act with patience. So patience and persistence and perseverance were really the most attitudes that I have to really learn and as well excel in order to enter and to gain the trust from the other parties, in order to really learn that this is now really a leader where they're not going to be like messing up in the middle of a conversation and embarrassing us as an institution or as a company from not being able to finalize a deal. So always having the challenge of staying a professional, but at the same time crossing those lines somehow in order to gain the trust and the friendly relationship with people.
Yeah. So, yeah, with that, I would like to talk about delegation. Jack, one of your recent articles was titled, "The skill that made you indispensable is the one you have to give away." So, could you please elaborate that?
I think what you have to do as a leader is be comfortable enough to. I'll just use myself as my example. So when I'm with a leadership team that works for me, or I'm working on a project with, um, whatever area that part of the project is, I want to empower the local leader for that area to, in essence, run the show, so to speak. So what I would do is, clearly articulate what the overall vision is for this project, and then empower them to come up with the ideas or the strategies on how to achieve their portion of that work. And, as the leader, your job is to be supportive and to remove roadblocks or barriers that are impeding their work. It sounds easy as I've described it. The hard part is, if you feel like that you're an expert in that area and you've done it before, giving up that and trusting others to complete the work or to do the work in a manner that may be different than what you would have decided upon or have pursued. So I think that's the biggest challenge, or one of the biggest challenges, is being comfortable enough to allow others to grow into that role and implement their own ideas, and be comfortable enough with yourself to allow that process to occur. And it's not an easy process.
So, is it the thought process, or is it the training that stops them not to think in the way that you described?
I think it could be a combination of both, or one or the other. I think depending on how long you've worked with a team, one of the things that I always try to do is to learn about them, learn what their skill sets are, do a personality assessment to figure out how to best tailor my message to them so that they receive it appropriately, versus a one-size-fits-all tool. And then over the course of that time, what I try to do is, as we're working on a project, I will ask them how they would have done it, and then I would say, I would do this or this maybe differently than what you did. Not to say what you were doing is wrong, but just so that they can begin to understand my thought process, and then hopefully combine the two to achieve, a superior train of thought versus just one or the other. So I think it's depending upon your time with the team. If it's a relatively new team that you're with, you're kind of at the mercy of their previous leader if they've been in this role for a little bit of time, or if they're a new leader in that space, then you really got to do a different level of mentoring and leadership development. So it's not a black and white answer. It's depending upon a lot of different factors.
Right. It definitely is not black and white, but I think with your experience, you nailed it, explaining it in a detailed way. So, Ramzia, like on the same line, I want to ask you a different question, maybe an opposite question to you. Like, are there some things that leaders should never delegate?
There are things that you have to keep for the top hierarchy, and the most important things are really the actual decisions that will change the whole institutional structure. Delegating a certain decision making within like a practical technique or technology, or a decision making in managing, decision making in, for example, recruiting somebody or given an idea of how good of a person could be, yes. But for example, if I want to delegate to a clinician to decide whether we want to implement a new service line, for example, similarly to a hospital, or a new technology to be added and have that business model or drawn to decide for the fate of the company itself, then no, that is definitely not acceptable. So there are things that I could delegate within a certain scope, having a maximum ceiling, for example, in implementation and operationals, in the inside job of the business itself on a daily operational basis. But when it comes to the big decisions of who could decide for the success of the institution itself, then that cannot be delegated unless really you have a partner with you in decision, not when you are the only sole entrepreneur in the institution. And that takes a lot of intensity and effort and clinical training, as well as really vision. You could have help from them giving you ideas, you could say, how could you have done this better? What would you think of if we added this, and have ideas from the people around you? You could really learn a lot, but the final decision should be really for that decision maker, because otherwise you could just, break down the whole system if it was taken from a different approach. So and sometimes even entrepreneurs take different wrong decisions. Not that I'm saying that because they're the entrepreneurs or the full owners of the company that they're going to be right. However, they would be more cautious because they have probably a longer experience, or they've been there and they've lost somehow, and they learn from their own mistakes. So when you're delegating, you're really still training and teaching people on how to do the things differently from your own perspective and your own experience, but not necessarily that this is the 100% correct way to do it.
So now I just want to explore where your experiences begin to diverge. Now I suspect you may see some things differently. So I just want to know both of your perspectives. Maybe I'll start with Ramzia. So Ramzia, what's something hospital executives don't understand about entrepreneurship in healthcare?
Yeah, hospital executives usually are trained under a hierarchy of a structure of a system that has policies, that has research, that has SOPs, that has its own ways of doing things that are preset to them. And usually it's a slower system to develop than entrepreneurs. When it comes to entrepreneurs, really, we have to teach hospitals how to act faster, how to be more innovative, but at the same time, we have to learn a little bit on how to be slower and how to take things a little bit, on a slow pace and think more in depth about it. But the only thing, the drawback is that in entrepreneurship, if you go too slow, then you're losing the opportunity. And in hospitals, if you are going too fast, you might be really losing a whole budgeting scheme that you might have been working on for like 2 to 3 years to implement and build. So there's always a very fine line between how to change things differently. But I would say, as Jack was mentioning, is with a Physician Leadership Academy, you are teaching more the skills on how to be entrepreneurs in hospital setting. When every person is acting as his own leader and as an entrepreneur for the benefit of the whole structure, then things will start moving faster but more efficiently. So that's what I would see would be a better implementation in a hospital setting, because you cannot change structure, you cannot change SOPs, you cannot change procedures, you cannot change research implementations, but you really can change people. You can influence people, and you can change people's way of thinking and how they vision things differently. So it's really about how we can all work as a team to change things differently, because the structure also has been implemented and put by humans. And this is where our main challenge is, to teach and to learn and to work with each other as a team. And this will really be very impactful, and it will make everybody excel at the same level.
I think because I've done both, my career started as in the hospital system as an executive, and then I've actually started my own business, so I would consider myself an entrepreneur now. I think the biggest difference, or the thing that it's hard to understand if you've never been in the health system, is I can't really come up with a good term, but for the U.S. as an example, what you're charging isn't the actual charge, and what you're getting isn't what you think you're getting from a reimbursement standpoint. And like all three of us in this room, for example, could have different insurance, and we'd all have the same exact procedure done. We may get charged something completely different, and the hospital system would get something reimbursed, something completely different from each of us. So that it's the diversity and the different levels of financial support, reimbursement, cost. It's really difficult to understand or grasp if you haven't been in that system for a lot of time. And as an entrepreneur, you understand your business intimately because you're doing everything in essence. So that's the biggest difference or the biggest gap or the thing that you would underestimate, I think, is it's not a simple system on the hospital side. It's very complex and very convoluted and difficult to understand.
Got it. So just wanted to know, do either of you disagree with the other's perspective?
I mean, I think for me, for Dr. Ramsey, I agree with her for the most part. I think um, it's on the hospital side. If you're not an entrepreneur, and this is just my experience, the majority of the people who are in leadership roles don't understand the complete picture. They don't understand the finances because they're not allowed to see the complete picture, um, and the layers of management are mind numbing. So I think that's probably the thing that I think that's that's not recognized. I think for me, it's been eye opening to start my own business and really have to know in the weeds everything coming from that health system side, which is your space, depending on the size or the scope of it, but your space, and I think that's the thing that I would not challenge her, but just add to what she was saying.
Yeah, Ramzia, any thoughts?
Yeah, other than what I have mentioned about really changing in people's personality as well as in people's thinking, like really more implementing the way people can analyze things differently. So, not being a blind set as this is my job and this is what I'm going to do, and I cannot really think outside the box. So, it's really how much of a leader you can influence your team or how much of a leader you can change in a clinical setting where you could give some kind of a life and joy to people's heart in the business where they would enjoy what they're doing, because now you are not that lenient, but you are giving them the freedom to think freely and to implement things they think it's gonna be beneficial on a financial setting as well as an implementation for the sustainability of the institution. So in a hospital setting, this is really tough because, as Jack mentioned, it's limited, and you always have to be run by laws and regulations and people setting those structural rules and regulations for you. But in a private clinical setting, no, teamwork can be really nice. It can expand, it can bring in new ideas, new innovations. People could be happy around each other, and that will give always a positive impact. So really a different culture, different setting, and smoothly going, with through the day without really going through all these hassles of reimbursement and policies and coding.
Yeah, no, thank you for answering this question, both of you, because I personally wanted to ask this question to both of you uh, at once, because now I have known an executive like who was doing a great job in his career. After some point of time, he made a decision to come out from the system, and then he started his own business. He became an entrepreneur, and then he failed miserably in a couple of years. And then he was at a crossroads because he couldn't go back as an executive, and then he couldn't excel as an entrepreneur. So, like you both are on those sides, so I just wanted to hear your perspective, and then also wanted to hear the opposite side of what are the pros and cons of these systems. I know some people might excel at the systems and then grow into the executive, and then some people absolutely excel at chaos in entrepreneurship. So, just wanted to know both of your perspective, and then I just want to build one more question on top of the same topic. So let's say I'll just take an example. Let's say if a talented physician come to both of you and then said, I have two opportunities. One is a leadership track inside a health system, and then the other one is building his own practice. What advice would you give? Maybe Jack, you can go first.
Yeah, let me just add this point to your example that you gave about the gentleman that was the executive and then went to be an entrepreneur, and this is my own experience, and I'm sure Dr. Ramsey could add or dispute it, but I think the biggest difference is you have to be comfortable like selling yourself or promoting yourself as an entrepreneur versus if you're an executive, you don't have to do that. It's just a completely different environment, and a lot of people struggle with like asking or selling their services. It's just a different mindset for them. Now to go back to your question, I think there's a lot of factors to consider. I think, and I can only speak for the U.S. market again. I think you're seeing currently a shift back to it being feasible professionally and economically for physicians to become a private practice again. And it depends on the specialties, but for example, the big trend in the U.S. is for cardiologists to either unwind their employment agreements because they can now operate in an ASC or an ambulatory surgery center. They can own part of it. They can control their own day. They can make more money, and they don't have to deal with any of the, structure of the health system. So they can go back to basically managing their day better. Whereas if I'm a cardiac surgeon, I still don't have that ability just because of the nature of the volume and the trends in the U.S. So my advice would be, is he in a specialty or are they in a specialty that is positioned to work in that sort of setting? And if they are, then my recommendation would be to either unwind your employment agreement and develop your own ambulatory surgery center or office-based lab and go back into that space. And you may need, a private equity investor initially, and you're likely going to have to hire somebody like myself, who's a business person, to help you manage your office. But knowing physicians who have made this decision and leap, they're much happier. They can actually make more money. So that would be my advice, is if you're in that space, then I would make the leap and I would go back to being an entrepreneur.
Got it. So, Ramzia, before I get to you, I just want to ask one more follow-up question on the same topic. Jack, you mentioned to hire PE, right, the private equity. I don't think any physician who was just working on the clinical side has no idea of how to hire someone, right? So, what is one advice that you give them, just to go and hire them, or just to go hire someone like you to guide them? What would be the best way, or at least the better way to approach this one?
So I think there's a couple of examples or models, and it really depends upon number one, the financial position of the physicians. So I'll just stick with a cardiology example. So if you're working in a practice and you all get along and you all consider yourself peers and colleagues, and you're in a financial position where you don't need an investor, my advice would be to hire somebody like myself to come in and do the business modeling for you. Now, if you are in a group of, let's say, 6, but there's only 2 of you that want to do this, you likely don't have the funds to make this leap on your own. So you can do a couple different things. You can there's a ton of private equity firms right now that are in this space. So you can do some research. You can hire an attorney to help you locate a viable company that is very transparent, and you don't have to worry about losing money because they're not a good company to work with. So that would be the other example. You likely don't have to pursue a private equity company. They're likely calling you already because that's how they make money as well. So you probably would have already a contact or two, and then the physician world is a small community. A lot of the doctors know one another. They likely have a friend or a colleague in a different area of the country that maybe has done this, and they would call them and just say, what's your experience been and who did you guys use, and go that route. So it really depends on what your baseline is. I think you're going to need somebody like myself regardless, but it's just a matter of, are you in a financial position and are there enough of you to stomach that investment versus if it's a small group within a bigger group, you likely need, some financial backing to go that route.
Awesome, thank you. Yeah, Ramzia, please give me your opinion or advice on this.
Yeah, I would. What Jack was mentioning really is very important, because if you want to give that advice, or you want to just to choose whether someone should join a clinical practice or hospital system, then you really have to make them aware of really the all the business aspects that they have to learn, and everything that we as entrepreneurs do and are experienced to do. But one thing is, I would first focus on, before I really go into that route of finances. And this happened to me a lot when people call me to do to train within my academy, because my academy is focused more on techniques and technologies in medical aesthetics and regenerative medicine. The first thing I tell them, they would come and tell me, I want to study this and this, and they would keep listing all these courses, and I know it would benefit my business and it would make me a good profit. But ethics come at first, because you have to really ask them, what do they really want out of these courses? Where do they feel themselves fit better? Is it the clinical uncertainty that keeps them thinking, or is it the operational uncertainty? Is it when they sit with like on their own and they start thinking, do they think of how to do a procedure better? Do they think how to excel better in operation, or how to get like better clinical expertise? Or is it how to make things differently in an operational setting, and how to expand their vision into having their own business and delegating the jobs to other people as well? So yes, here you really need to know the technique and the technology, but you don't always have to do it in your own hands. And this is where I start, and I had a lot of cases where people really would not register for all the courses that they were so intrigued to tell me that I'm excited and I want to do it and I want to go forward. But then at the end of the day, I say, okay, so if you really want to train on this machine, do you really have the budget to invest in it? Because if you don't invest in it right away and start to practicing, then you're not going to be making money. So are you wanting to do this, or is it going to be a waste of time and money for you to study the course and then keep the certificate in a closet? So this is where really the finances are very important, but at the same time, this is where I can tell if a person is really persistent, or if they're not really sure what they really want out of their own life. And my conversation with them would start to really redirect their thoughts into learning from them, whether they are really just clinicians and they should be only employees, or they could really be business owners. And this is very important, because learning behaviors and understanding people's perspectives and listening to people, understanding what they want to do out of the thing that they're studying, or how do they want to implement it. I ask open-ended questions. I say, so tell me how you want to do this. So let's say I teach you about hydrofacial, or I teach you about microneedling. What are your plans? And most of the time I find out that they don't even have the finances to do that. Another thing is that I would probably advise them that, what do you do now? What are we working? How about we could change a little bit of that setting where you're working, and giving you more exposure to the technologies that you will be studying in my own. Sometimes I offer in my own clinic to be their own place for practice and experience. And once they are competent, because it's not important only to be trained, but you really have to show competence, that now you are trained, but you can counsel, the art of consultancy, and you can start making profit. After I make sure that this is the time where they really start to make profit, is I would tell them, okay, maybe now you are really ready to transition, because you have gained the total experience from an institution, and you are not really taking that institution as your final stage of your career. So this is very important. Most of the times, a lot of people who need that extra training would have to belong more to institution before they become entrepreneurship. And that would probably give them a much more benefit when they are not sure of what to do when they decide to do it. So that's really very important, because I tend to analyze it from totally different perspective than just, whether they can afford it or not. Because otherwise, yes, as Jack said, they're not going to only be hiring Jack, but they're going to be going through a hassle of a lot of anxiety and stress, learning more from Jack and from others how to implement every single idea, because now they want to be the leaders, but there's a conflict between the leaders and the people or the person who they have hired.
Yeah, I just want to ask Jack on the anxiety part of it. Jack, where do you see the clinicians who wants to transition into leadership skill? Do you often see them go through anxiety and burnouts, or do you see them whoever fits into it, just they get fit into it, and then whoever doesn't get fitted, they go back to just practicing whatever they're practicing back into the system?
You're asking me about physicians who want to be leaders and then are not successful. Do they transition back into the health system? Is that right?
Yeah.
Okay. So there's a couple of mechanisms in place for a lot of health systems that is a fail-safe, so to speak. So initially what they'll ask a physician to do would be become a medical director for a particular service, and that's usually a senior physician who has expressed interest in leadership. And it's like dipping your toe in the water, so to speak, because there's not a lot to ask of you as a medical director. It's more of a formality, but it allows a physician to be exposed to what leadership is, and they have more time with somebody like myself who's assistant vice president or a senior vice president of a health system for a particular set of services. The good part about that for the organization is there's a term to that contract. So usually it's a couple of years, and there's always, depending on the organization, either a 30 or a 90-day out of any contract. So on the organization side, if the physician is a disaster, so to speak, they can end the relationship earlier, but it doesn't affect their employment agreement. They just go back to being part of, that group of cardiologists or neurologists or whoever. But then if they excel in that space, then that kind of lets the organization know, hey, this is somebody that we can invest in. And maybe they have a physician leadership academy or some sort of formal training, so they can prep that particular physician to either be chief medical officer or sit on the QIC, which is like a clinical quality for leaders, that if there's a bad outcome, that physician sits on that board. So there's avenues for them to do that. But in essence, to answer your question, if a physician either decides I don't like being a leader or I'm not very good at being a leader, yes, they go back to just being part of their practice again, with no ramifications on their employment status or their status in general. I think it's more probably a dent in the ego of the physician that I tried this and I failed at it versus their standing in the organization.
So AI is making knowledge more accessible than ever right now, and a lot of people they just keep on getting into the rat hole of just asking question after question. And even these LLMs like ChatGPT or Gemini are good enough to put you in that endless loop of 8, asking you more questions. So where is it going with now with such a lot of information? That is making the clinical knowledge becomes less scarce, and then what becomes more valuable now in the healthcare in the healthcare leadership position.
So with the AI, really, it has its pros and cons in healthcare system. As you know, there are lots of research among the world actually that is happening for healthcare, and they are investing millions of dollars in that aspect, whether it's in regenerative medicine, whether it's in aesthetic medicine, or in just like technologies such as in radiology and medical labs, and you name it. We have a lot of technologies in AI, but the mistake and the dependency on that AI solely is where the clinician will start really not being able to analyze and think of the ways of how they should do things and not how the system is telling them to do it. So it's very important to understand that AI is being trained by humans and what the human knowledge is. And always there is a ceiling of that knowledge to be embedded within a certain AI platform or a chatbot or or within a machine or a system or a target, because really when you create that AI, you are teaching the AI what they could know, and you are coding that AI what they are allowed to do as a task and what they're not allowed to do as a task, or when they say I can't do it and I fail it. And this is where the human thinking has to come into a place. So the AI, I would say the benefits of it is really excellent in the speed of innovating in new technologies and making our lives easier operationally in an operational setting. Even the robots that are helping now in plastic surgery setting in hospitals, in surgical interventions. But still, we cannot rely solely on that, because an error might always happen. And this is where we have to be really depending on our medical knowledge and on our critical thinking and analysis. So that's why, yes, it's an exploration and it's a huge impact that's being caused all over the world, making our life easier. But at the same time, we always have to take both sides and not depend solely on it.
Yeah. So Jack, would love to hear your perspective on this.
There's a few things. So on the clinical side, right now, all of the AI, one of the examples I'll use is radiology. So AI reads every scan, X-ray test first, and it's overread by a radiologist. Now, over the course of time, as AI progresses, it's going to, I believe, probably eliminate a lot of radiologists, because the speed of AI and the accuracy of AI is going to surpass a human. But currently it's in that space where it's, to Dr. Ramzia's point, it's validated by a human. And other specialties, and I'll use neurosurgery or spine surgery. So there are robotics with AI embedded. So as an example, there's a program for neurosurgery that will actually, you'll put it on the screen, there'll be an image of the patient's tumor in their brain, so to speak, and the AI tool will give the surgeon the optimum path to reach the target or the tumor with the least amount of damage done to the brain tissue. So again, that's on the surgeon to decide if that's the right course of action or not, but that wasn't available even a couple of years ago. Spine surgery, the same thing. They can map out the location. They can use a robot, which is much more accurate in placing a screw than a human is. So theoretically, you get improved outcomes or better outcomes. From a cardiology standpoint, the example I can use is a physician could be sitting in New York and the patient could be in Baltimore. They can robotically do the cardiac cath intervention sitting in New York with robotics and AI. Then they don't physically have to be in the room any longer. Now that's a rarity at this point, but it's at the point where it is happening. On the non-clinician side, or in the health systems, for somebody like myself or business people, it's going to eliminate a lot of jobs, I think, relatively soon. If you're a data analyst, or if you're a paralegal, anybody that does like basic finances, AI can do all that stuff now faster, more accurately. Again, it's all validated by a human at this point, but I think that's the trend that you'll see on the non-clinical side of AI, and it's only going to keep progressing, to get better and better.
Well, if AI keeps progressing for better and better, do you think healthcare costs gonna go down because of the vast availability of the advice and also huge reduction of time of surgeons and physicians treating each patient?
I mean, yes and no. There's a lot of factors. I mean, if you're talking about strictly a diagnosis and a care plan to get the patient out of the hospital sooner, yes. If the health system's having to rely upon a particular product or device, and that product is made in China, you're really at the mercy of what is the transport cost, what is the cost of the device in China, are there any tariffs on the product? So it's not as simple as AI is going to make that cheaper, unless, of course, everybody just starts to manufacture their own stuff with like 3D printing as an example. So theoretically it could, I think what you'll see is a higher level of quality, better outcomes, and faster throughput into the system versus cost per care, or cost of care for that surgical procedure has more factors involved than, if you just go in and you're sick and they're just trying to make you well and get you out of the hospital. I think, yes, that will definitely get better and cheaper. I'm not so sure about the other side.
I got it. Yeah, Ramzia, please go ahead.
In our clinical practice, actually, in private setting, it's really costly because now you are adding the system that's going to be the same price in a hospital setting for like a larger group of people, going to be equally this almost the same value in a small clinical setting. And why is that? Because once you start depending on it and you put all your CRM and your database inside an AI system, you will not be able to eliminate it easily from your workspace. And this is really a costly implementation in your system because now, well, it's costly, but then it will still take time for that AI system to be running on its own and to really start delegating that extra traffic of people and funneling more patients to your clinic and start balancing your cost versus your profit or your return on investment. So this is where the challenge comes. Yes, it would be much easier for us, and it might eliminate a lot of working hours for employees to come because now you can have your own chatbots that can reply automatically to the messages. You won't be able to miss any missed call. You will be able to have your social media preset as well with AI marketing. People will start seeing you more, but for every single step that you are having as an advantage, you're paying a cost. And for that cost, sometimes it could be really more expensive than just hiring a person who can do it for you. But nevertheless, it is really advantageous. It will give you a lot of implication to focus more on what you are doing in your clinic as per your clinical programs, your clinical outcomes. But at the same time, you have to really think, if I really embed that AI system and get an extra 20 clients, this is really nice. Am I able to really treat them and give them the same quality of work clinically than I would have been if I had only 10 clients a day? So now really you have to really weigh the quality that you are giving to your patient and how individualized you are being with your patient care versus really just to add numbers to your system because you want to make higher ROI, but then you might be losing then the quality of patient care. So really, you have to think it very wisely, according to the system you are in, and according to the really the size of business that you are in. Each business is different. Each business has a different perspective, and you might end up having to employ more people to be able to cover that extra traffic that's coming from an AI. And now this is both ways. It's going to be higher and higher cost. So higher cost means higher retail price. Higher retail price means thinking about patients' acceptability. So it's a lot in depth that we think about before we really implement any of those systems in our clinical settings.
Yeah, I think that's a good different perspective on the cost. So before we wrap up, one final question. So like maybe 3 to 5 years from now, what leadership skill will healthcare wish it had started teaching today?
It's hard to predict just because things change so rapidly. I mean, I think if you would have said a couple of years ago, private equity and physicians would be unwinding employment agreements and moving out of the hospital system, people would have said you were crazy. I think the skill in general, I don't even know if it's leadership. I think just the skill in general is the ability to adapt and to pivot because I think, or change management. I think just because things are going to keep changing so rapidly, I don't think the pace of change will slow down, particularly with, AI becoming more and more advanced and the healthcare environment changing. I think that's probably the skill that I would say the most. I think just like we talked about with radiologists, in 3 to 5 years, that may be a specialty that's gone. I mean, so I think change management or just adaptability would be the thing that I would want to teach people.
Perfect. I think adapting is the key. So yeah, Ramzi, please go ahead, please.
What I would see actually, and what I advise a lot of people, and even my 9-year-old son now, is how to create his own vision into empowering himself, or my clients to empower themselves to really do more than one thing at a time and not depend on only one task to have income out of. Because with all the creations and the new stuff, and which we don't really know what is going to happen in 3 to 5 years from now, but if what we are seeing now is going to be more and more expanding and excelling more, then really every person and every child, we should really teach them to learn about AI as well as coding and digital marketing. I think those would be the core computer skills, the core skills of how to build our next generations with any other specialty that they want to think of doing in the future. And that's what I've been investing in my actually son since I was 4 years old. So you really have to teach them the STEM, the STEAM, then a new way of thinking strategically and how to manage their own money. It's very important to learn to teach kids from a younger age on the concept of management rather than just to think that they can earn anything when they want it is just because it's there and available for granted from them. So basically, these are the skill-based teaching ladders that we have to emphasize on in our schools, in our systems, and in our homes as well.
Awesome. Yeah, Ramzia, Zach, thank you for joining me today. This has been an incredibly thoughtful conversation. I really appreciate you giving us the time. So to our listeners, thank you for tuning into Healthcare Business Growth Conversations. If you enjoyed today's episode, be sure to subscribe and also be sure to reach out to Ramzia and Jack. Thank you.